Hello everyone. Good evening and best Friday to all. And welcome to our first podcast episodes. Today we are talking about keratoconus and to see how to decode the keratoconus and what's the latest research in this field. First of all, I'm thrilled to introduce our guest, Dr. Ammar Issa. He's a senior consultant ophthalmologist with impressive credentials, including FRCS Glasgow. He has a postgraduate degree from Edinburgh, from Ireland, with a degree in cataract and refractive surgery and dealing with keratoconus. I had the honor of working with him under his supervision at Ibn al-Haytham Hospital when he was the former manager. For those who don't know, Ibn al-Haytham Hospital, it is the largest tertiary eye hospital in Iraq. And Dr. Ammar is also a founder and manager of the Corneal Advanced Cataract and Refractive Surgery fellowship programs with over 20 years of teaching and experience in the field and managing keratoconus cases since 2008.
Oh, yes.
So a big thank you for Ajanta Pharmaceutical team for their support and also for providing the logistics and venue. And for all colleagues and who are following us, you can feel free to send your questions to the Q&A box or in the chat box, and we'll talk through them at the end of the session. So without further ado, let's dive into this exciting topic. Just a notice that our Zoom meeting today will be in hybrid, both in Arabic and English, because I think it's be more appropriate. صح؟
More probably, yes. All right.
زين. نبدأ بأول سؤال اللي هو السؤال التقليدي. We'll start our talk with four main logistics. We'll start with just like an overview of keratoconus, how it's going, how the disease is processing. The second thing we want to know is that about the diagnosis, which last things and diagnosis, and further with the natural progress of the disease and with the treatment. So we know that keratoconus is associated with a lot of systemic diseases, right? So what's the main systemic disease that you're concerned with keratoconus?
The systemic diseases in keratoconus are multivariated. You have two different types probably. We talk always about ocular diseases, which may have systemic manifestations like Marfan syndrome and things alike. And at the same time, we talk a lot about systemic diseases, most notably atopic diseases in which there is some sort of allergy and which invites the patient to rub the eyes, like in atopic dermatitis, a lot of skin allergies. But in addition, there are some diseases which they do not link directly in terms of atopy, like thyroid diseases, autoimmune diseases. Many of these diseases, sometimes they have an association with keratoconus. Just for the sake of giving something nice, I have patients with migraine. They have the keratoconus. And usually those patients, they are females in their 40s. When you ask them, why do you have this sort of ailment to the eye, you have keratoconus, and you dig into the history, you will find that those patients, sometimes they have the traditional way of managing headaches, like rubbing or tying something around the eye and around the forehead in an aggressive way. And that's why usually on the side of having the headache most commonly, they will have also keratoconus. I have several, 2 or 3 patients of the same pathology.
We have the case report this.
Yes,
for sure.
So
you talk about rubbing, and you see that rubbing is a major cause of progression of keratoconus. But the question is, how do you manage this? Okay, I know that you ask the patient to avoid rubbings as possible, but what about your protocols of treatments with allergic patients, those who have atopic patients?
Just to make it clear, there are 2 theories about the etiology of keratoconus. One of them is the mechanical theory, which we talk about a lot. Most of the authorities now, they consider mechanical theory is the main direct cause of keratoconus. And there is an inflammatory theory in which there are inflammatory mediators in the cornea caused by atopy or something else, we don't know. And these things will trigger the cascade of inflammation, release of mediators, eye rubbing, and keratoconus formation. So probably the final pathway for the immediate cause for the keratoconus is the eye rubbing. That's why it's very important that you and everybody, I mean the ophthalmic community, know that eye rubbing and continuous pressure on the eye during sleep, because sometimes the patients, they don't have eye rubbing in terms of habitual eye rubbing.
They're not aware of.
متعودين عليه مثلا بس مجرد انه يفرك بعينه او it's an allergic type of eye rubbing, but they have sometimes some habit of sleeping with their hands probably under the eyes or the pillow rubbing against the eye, and that's why they get the same effect of doing eye rubbing. How to manage eye rubbing is related to the cause of eye rubbing. This is very important.
Okay.
Because if it's just habitual eye rubbing, or it's a matter of sleeping face down position,
yes,
you will advise the patient to avoid. Sometimes I advise patients for the sleep, because many patients, they will tell you, I cannot, this is my way of sleep for the last 15 or 20 years. I cannot now change it to a different way. I will advise them to wear goggles, large type of goggles, just like the motorbike, eye goggles, probably, and just the same treatment of allergy. If there is allergy, we treat the allergy. If there is dryness, we treat the dryness.
So there is a lot of debate that this may be also related to the causes of that there is a hereditary causes of keratoconus, and a lot of researchers that have read that there is subclinical keratoconus in siblings and father and mother. And for my questions clinically, if you have a patient with keratoconus, do you put their siblings, mother or father, on topography or not? Is it a common practice?
It's not a common practice. Usually, what we see siblings. Probably it is said that the percent is around 10% or less. Okay, they have something of hereditary, but what we see that those families, when the community they live in is the same, so usually the environmental trigger for the allergy is probably the same, and I believe this is the cause for the keratoconus. They rub the eyes, whether it is the big brother.
Yeah, it's environmental causes. It's household
mostly
causes.
Environmental. Yes, research has shown that there is some sort of genes related to keratoconus in families, but the causation, exact relationship to the cause of keratoconus is not proven. That's why we call it's a multifactorial disease.
So if you have a patient that's coming to your clinic and he has like symptoms of keratoconus, mainly it's an astigmatism. And what do you think, what caught your attention? Do you have any patients with astigmatism, you send it, or you have some criteria for astigmatism to check for keratoconus?
There is no criteria really in terms of for very early cases. The new incidence of astigmatism, the astigmatism with the presence of a lower than normal best corrected vision, okay, astigmatism in the presence of an abnormal retinoscopic reflex, all these things, young astigmatism in the younger patients, 12 years, 10 years, 15 years, I'd rather do screening for them for keratoconus, especially if they have any other symptoms of eye rubbing and allergy.
So what's your first initial steps in the diagnosis of keratoconus? Guide us through the process. Guide us through the process. You see that this is a patient that you may suspect that he has a keratoconus, like for example, he has like irregular astigmatism or something. What's your steps? What you're doing for the patients?
Apart from doing refraction, doing retinoscopy and seeing the retinoscopic reflex, if you decide to do, if you tell me you need a single investigation, just to screen the patients, you'll do a topography. Whatever the type of topography, it will screen for the presence of keratoconus. At least it will differentiate if this is a frank type, if I can diagnose this a frank type of keratoconus, or it's a suspect type of keratoconus. If it's a suspect, we'll dive into further tests probably later on in the process. But if it is frankly obvious from any type of topography, that's it. This is keratoconus.
What do you mean by any type of topography? What are your types?
You know, topography is, they have two main things nowadays. Previously, probably many years ago, there were 3 types, but now it's mainly 2 types. You have the Placido type of topographers, and you have the Shamifluke type of topographers, or the combined forms, of course. Before there were some slit scanning like Orbiscan, some raster stereo keratography. You know, these things are not widely spread, but the widespread use now is the Placido and the Shamifluke. Both of them, they can diagnose an established form of keratoconus. But if you have a case which is like subclinical, when you say it's subclinical or it's an early form, sometimes the Placido topographers, because of the issue, you know, of epithelial masking, the Placido, although it's more accurate in defining the corneal curvature rather than the Shamifluke imaging, the problem, it misses early cases because of the epithelial remodeling.
So, if I was working in a periphery, like in the villages, I don't have any Shamifluke topographers or any type of topographers to be done. What is the first clinical sign that I can do? I have retinoscopy. You said that there is
retinoscopy is the
and I have a slit lamp.
Yes,
that's
retinoscopy. The slit lamp is completely normal. You will not see anything. Very rarely these signs, you know, with the clinical thing like the prominent corneal nerves, increasing of the curvature, thinning, probably localized thinning in one area, Vogt striae, scarring, whatever, Munson sign, all these are late and very easy to find. You know, we are not talking about these findings. These findings are now just something of the past, probably, because we need to encourage ophthalmologists to catch keratoconus very early. And usually very early, it means these signs are absent. So we are left with detection of irregular astigmatism. Detection of irregular astigmatism, it needs a knowledge that the best corrected vision is not getting 20/20 or better. Most of the people in our community now, by the way, يعتقدون أنه ال 20/20 أو ال 6/6 هو ال best vision. بالحقيقة ال 6/6 is not the best vision. احنا أي واحد بينا يفحص من الشباب خاصة، بس احنا يجوز شوية تقدمنا بالعمر نختلف، بس الشباب definitely better than 6/6. يعني ما بيها مجال. الافريج فيجن اعتقد هو 6 over 4 point something الافريج فيجن. فدائما هو بالحقيقة النظر المفروض أفضل من 6/6. So usually you have to refract your patient to a vision better than 6/6. If you can do this, very rarely you have astigmatism. I did not see any case like this.
Okay.
And when you have a regular cornea, you don't have these types unless these for very remote things and refractive surgery. We can talk later on this. عدا هذه انه انت المريض اذا ما وصل الى 6/6 vision مع retinoscopic findings, even without having a topographer, you can be like 90% sure this could be a keratoconus case.
Okay. Sorry, we must have another host with us, with Dr. Mu'taz, but unfortunately, because of he must join us on live, but I think sound cannot be corrected. But he sends us some questions. One of them is that if you send the patients for topographers, what are the common topographic patterns associated with keratoconus?
إذا نرجع إلى التopography, we have to think about the Rabinowitz criteria of the shapes of the cornea, okay, in general. So most of the time in keratoconus, you will find some sort of inferior steepening or asymmetric bow tie, okay, with or without skewing. This is the main type of keratoconus we see in our community. Yes, there is a variety which is superior corneal asymmetry, a variety of regular bow tie, a truncated, we call it regular bow tie, but a small bow tie. This is also a risk or a type of keratoconus. But the most common inferior steepening or an irregular bow tie or asymmetric bow tie with or without skewing. This is the main finding you can rely on for keratoconus detection.
And he also said that
this is about curvature maps, by the way.
Maps
I'm talking about curvature maps.
Okay. And he also asks about how does the anterior segment OCT works with detection of keratoconus.
الترند الحالي طبعا خلال السنوات الأخيرة أنه دخول الانتيريور سيجمنت او سي تي بقوة في مجال تشخيص keratoconus. الفكرة الأساسية أنه the main idea of the anterior segment OCT is to detect the epithelial and the stromal findings, okay, which may mask each other. The epithelium can mask the stromal findings. So separating the epithelial changes, which is a capability only for the OCT at the moment. Sham fluid imaging cannot detect the epithelium with high accuracy. So the epithelium, you can judge the architecture of the epithelium, the behavior of the epithelium in regard to the stroma, underlying stroma, using the anterior segment OCT. And that's why now it's an integrated part, the anterior segment OCT. And some instruments, it's integrated with a Placido topographer, like the MS-39, in the same device, to aid in the diagnosis of keratoconus, and a lot of research.
So do you use it? Do you use it nowadays?
At the moment, I do not use the integrated variety. إن شاء الله قريبا يكون موجود. But at the moment, we have a separate pachymetric maps, including the epithelial mapping, plus the sham fluid imaging and the combined Placido.
Okay, and a lot of debate that the thickness of the corneas makes a lot of speaks about how to manage the corneas between various devices used in the pachymetry. Which one do you prefer, the ultrasonic, the optical system, or what?
لا هي نقطة مهمة. شنو صحيح كلامك هذا. الالتراسونيك pachymetry is the gold standard.
Gold standard.
For the gold standard in terms of like standardization of thicknesses before. Because this is the first instrument to measure more or less accurately the cornea. So when you see some findings, or the old findings of having the normal cornea thickness like this, 540 or something, you have thickened cornea more than 600, all these things, they are related to the ultrasonic pachymetry. Nevertheless, this is not the most accurate method of measuring pachymetry. Okay, at the moment, very few people, I don't know if anybody using, unless use intraoperative ultrasonic pachymetry for certain purposes. The trend is using some other devices like sham fluid imaging and the anterior segment OCT. Usually the sham fluid imaging and the anterior segment OCT, the difference is minimal in normal corneas. But when you have a cornea which is diseased in terms of scarring, thin corneas, okay, usually the anterior segment over OCT will be more accurate. Yes, will surpass the accuracy of the sham fluid imaging.
And there is also a lot of debate about the posterior elevation and the precise location of the posterior elevation. Do you think that this is a practical thing?
هذه نقطة واحدة أتذكر في مرة مؤتمر قديم في سنغافورة قبل 12 سنة يمكن. كان ستيفن كلايس موجود ومايكل بلين اللي هم ذول يعني واحد منهم الفاذر اوف بلاسيدو diagnosing keratoconus using the Placido topographer, وواحد من father of diagnosing keratoconus by the posterior surface changes. يعني فكان عندهم ديبيت قوي جدا، وهذا ما وصل نتيجة بالحقيقة يعني في وقتها. يعني حلها بعد فترة يعني دان راينشتاين يقول انه السبب الرئيسي هو الابيثيليال تشينجز.
اوكي، هو هذا السؤال كان يعني انت
بالحقيقة هو الفكرة وين البلاسيدو توبوغرافرز in detecting the curvature changes بالanterior surface they are the most accurate، ولذلك انت تشوف بعض الأجهزة دخلوا البلاسيدو توبوغرافر على الشام فلويد ايميجينج.
اوكي،
الشام فلويد ايميجينج يقدر يطلع لك البوستير، بس الانتيرير اللي بيكون موشن ارتيفاكت، هي مشكلة الموشن ارتيفاكت بالحقيقة. فالبلاسيدو توبوغرافرز لأنه صورة هو دي ياخذ لحظية هاي الصورة، بينما الشام فلويد ايميجينج ياخذ سكانينج فيحتاج وقت. هذا الوقت بالحقيقة يصير بالموشن ارتيفاكت ما تصير بالبلاسيدو توبوغرافرز. فبقى هو الشام فلويد ايميجينج for detection of corneal thickness and the posterior surface. الانتير سيرفيس البلاسيدو توبوغرافرز. من اللي راح يلعب دور يقول انه هو التشينجز تكون posterior لو anterior؟ هو الابيثيليال changes. فinitially when there is a capacity of the epithelium is to mask the anterior surface، طبعا البوستيريور سيرفيس changes will appear. بس اذا انت اجيت حاليا واستعملت anterior segment OCT مي البلاسيدو، ممكن تشوف التشينجز اللي موجوده حتى بالانتيريور سيرفيس
بدون النظر للبوستيريور،
لان هم both of them they change. يعني الديسبيسمنت هي بالحقيقه it's not a matter of يعني اكو displacement initially، both of them anterior and posterior.
So also there's significant studies about the corneal biomechanics in detecting keratoconus.
صراحه ما عندي الخبره الكبيره بها جدا. السبب الرئيسي ليش؟ لانه لحد الان موجود اوفرلاب بين النورمال corneas biomechanical indices of normal corneas and corneas with keratoconus او keratoconus suspect او formofloss keratoconus او whatever. فلذلك بالحقيقه نعم الكوربس يمكن اجى شوي افضل as additional tool in reaching the diagnosis او confirming the diagnosis. بس بقى هي بالحقيقه واحده ما تقدر تعتمد عليها، انه تقول البايوميكانكس وحدها ممكن اعتمد عليها في تشخيص الكيراتوكونس صعبه شويه.
احنا بالعراق عندنا كوربس.
اي موجود،
اتوقع موجود
اكثر من
والاذر ديفايسز الاوكيولار ريسبونس انالايزر ما اتوقع.
اوكي ريسبونس انالايزر بالحقيقه توقف انتاجه على حد علمي، توقف لان السبب الاكيورسي مالته قليله جدا.
وهذا جواب.
بس بقى الكوربس موجود.
زين، يعني فلنفرض بانه you want to make like a super quality units of detecting keratoconus. What are your winning courses؟ شنو هم الاشياء تشوفها انت رابحه يعني هل راح تجيب راح تجيب topographer which type of them؟ طبعا there is no financial disclosure about any devices. واحد. والشغله الثانيه will you bring Corbis او you bring مثلا corneal biomechanics devices ولا لا؟
هذه تعتمد صراحه على الاكسبيرينس. يعني هي انا اقول هي المين ستيز اوف diagnosis هو عندك تو ماشينز اللي هي شام فلوك ايميجينج usually combined with the placido topographer. انت حصلت العالمين هذه البلاسيدو صار عندك والشام فلوك موجود عندك وسم سورت اوف epithelial mapping. هذه مسألتين الرئيسيه اذا غطيتها انا اعتقد with good experience ما تحتاج جدا البايوميكانيكال انسترومنت. البايوميكانيكال انسترومنت قلت لك هو confirming diagnosis وممكن for research purposes ممكن اني ايضا يفيد طبعا.
زين. Any new advanced technologies that you are aware of that can make everything changes?
هي الادفانس تكنولوجي حاليا بالحقيقه يعني تدري كميه الداتا اللي موجوده من الماشينز هذه كميه مهوله بالحقيقه. يعني هي احنا نبقى نعتمد على الفيجوال دايجنوزز اوف ثينكس بس هو في ارقام كثيره جدا a lot of numbers a lot of indices. انا اعتقد النكست ستيج هو how to combine all these findings from different modalities of testing مثل اهل الرتنا شلون عندهم مالتي موديل retinal scans وكذا اللي هو functional and structural يعني both functional and structural things how to combine all together to give a certain index okay او certain probability of diagnosing keratoconus اللي هو هذا مهم خصوصا للناس اللي ما تشتغل كثره في هذا المجال. انا اعتقد العمل يمشي باتجاه الديجيتايزيشن اوف ثينجز الارتفيشال انتليجنس اكثر.
هو هذا سؤالي الثاني انه
هذا شغل موجود يعني صراحه.
يعني you are aware of AI technologies in doing detection of keratoconus يعني ممكن نشوف الايام الجايه
يعني ممكن ريناتو امبروزيو واحد من الناس اللي عنده جروب تشتغل في بروجكت اسمه برين بروجكت تصور هذا راح يدمجون كل الداتا اللي موجوده من الماشينز الايميجينج ماشينز هذه بالحقيقه اضافه الى كلينيكال فايندينجز فيساعدون. انا اعتقد هذه مستقبلا راح تساعد بالتشخيص بكثره يعني.
So let's suppose that you met a patient, you send him for topography, tomography, and you see, and you diagnose a patient with keratoconus, um, and he is like an 18, because this is the debatable topic. What to do next? What's the natural criteria for progression? How do you see that? How do you say that this is a progressed keratoconus or not?
يعني قبل البروجريشن مو انت يعني الدايجنوزس اوف كيراتوكونس واحده ككلمه كيراتوكونس انا اعتقد قبلها تسبقها مراحل يعني احنا اللي نشوفه مرات الاصعب من عنده انه if you have a patient who is a keratoconus suspect ازيد من عنده. هسه تقول لي كيراتوكونس يعني بيرسي وموجود وانت شخصته وتعرف هذا كيراتوكونس. عاده الهيستوري صراحه الهيستوري هو اللي يحدد لك. اذا تقول لي باليونجر بيشنت نقول below 21 years or 20 years. الهيستوري is the main thing which I rely on to say this is a progressive type of keratoconus or not. History in terms
past
of not
or a future history, because you
past
can
history.
past history.
لا past history يعني انت يعني قصدي يعني فاهم المساله انه انت تريد تعرف انه هذا مريض عمره 20 سنه او 18 سنه وdiagnosed him with keratoconus bilateral established keratoconus asymmetrical one eye more than the other وهو عنده history already of eye rubbing نقول اكو فد inciting factor او predisposing factor. انت تريد تعرف هل هذا المريض انه will subject him to invasive treatment or not.
Yes.
النقطة الأساسية اللي ممكن تعتمد عليها about the history of the patient طبعا. هسه هذا الهيستوري how much valid in our society مو كل مرة طبعا أنت can swear that إنه the patient is saying the exact truth يعني اللي تتخيلها. مع ذلك إنه أنت you should have a judgment about the severity of keratoconus. If you see that, for example, I see a patient with 6/6 vision. Okay, there is keratoconus. Okay, I can diagnose keratoconus on topography, but still, he can reach 6/6 vision. The other eye probably less 6/12 or 6/18. Do I need to subject both eyes for the treatment? Sometimes not. Okay, sometimes not. I will subject one eye for the treatment, the more severely affected eye, and then advise the patient to wait and observe for the other eye. If the patient below 12 years age, probably no, I'll do cross-linking both eyes. Immediately, because those patients usually they progress within 1 to 3 months. You cannot catch them, okay, easily. But the patient with 18 or 19 years or 20 years, no, you can wait. You can wait for 6 months, 3 to 6 months usually. We repeat the topography and we see if there is any progression.
The most important parameter to detect the progression is the VA, thickness.
There is no single parameter. The problem, I cannot rely on a single parameter. Some people, they say, for example, if you have a change in topography or a steepest topographic point of more than 1 diopter or more than 1.5 diopter, okay, over 6 months to 1 year, you cannot rely on. Because usually the repeatability of it, you have to keep this in mind, and everybody hearing us or seeing us now, you have to keep in mind that the repeatability of the test, if you have a diseased cornea, is not like a normal cornea. Okay. When you have a diseased cornea, usually the repeatability is low. So you test the patient today and you test the patient tomorrow, and you see difference. Okay, and usually this difference does not signify anything. It's just variability of the testing.
Yeah, misleading.
طبعا. Okay. Variability of the testing. كل ما تكون الكورنيا steeper, كل ما تكون الكورنيا irregular, كل ما variability راح تكون more. So when you decide if there is progression or not, usually I will do the test and then I repeat after 1 month, just to make sure إنه this test is valid. هاي نقطة مهمة بالنسبة لي. بس هو usually if we talk about progression is a constellation of signs and symptoms. It's not something single parameter. You tell me, for example, corneal thickness. How many patients you do cross-linking, and then after cross-linking, you do the topography, you see the thickness is less.
Yeah, there's a lot. Yeah.
Less because of what? We don't know, by the way. Maybe the schemophilic imaging, when you have a scarred cornea, does not detect the thickness well. So it gives you lower thickness. Okay.
So
maybe something else, maybe measurement, maybe epithelial changes.
yeah.
So,
Because it's not that clear, it's
signs,
debatable.
no. Signs and symptoms.
Yeah.
Usually, you ask the patient. Patient usually, with the history, they are reliable. The history is more reliable than the examination, by the way.
And you mean by history, just to elaborate things that changing
It's
of
the
glasses,
changing vision, worsening vision. Okay, not only the glasses. Glasses you cannot rely also because different refractionists, different techniques. Some people they give for -5, they give -1 or -2. This is it depends on the trend,
Depends,
also.
Yeah. And if we have a patient with keratoconus, what are the initial management strategy for mild cases? Mild. We see by mild, like his vision is okay, but you see that he has an epithelial thickness maps that's below normal, or he has posterior elevation if you are not depending on the epithelial thickness maps. And you put the patients on glasses, contact lenses. What's your preferred method of treatment?
So we see a lot of those patients. Why? Coming for refractive surgery.
Yeah.
And those patients, they have a form of, previously we were talking about form of lost keratoconus. Now they talk about subclinical keratoconus. Those patients, they don't need any management, by the way. They just need observation and prevention of any predisposing factor for keratoconus. If you have a patient who is used to rub the eyes, okay, while reading, for example, because of some dryness, okay, you treat the dryness, that's it. Otherwise, you just observe and follow up the patient within a few months.
So, okay, but let's
depending on the
patient,
age,
yeah, okay, but the patient is still he sees that he needs some refractive corrections. So, do you prefer contact lenses over glasses, or you can go with the glasses just?
Glasses.
Just glasses.
Contact lenses, they are not widely used here, but still for females, for example, they can use contact lenses.
So I've seen a lot of someone who is doing something what's called like he's putting bandage contact lenses with 0 power for patients with mild keratoconus.
Why?
He sees that it's a well between the interface between the tear between the cornea and the contact lens will correct everything, and then he puts some glasses on. I don't know.
Yeah, there is a way of doing rigid cast permeable lenses, okay, which is called the piggyback technique. Piggyback technique, you put a soft contact lens, and then you put the RGP on top of it. But usually, soft contact lenses usually they stick to the cornea. They don't have fluid well, or fluid reservoir behind the lens itself, not like the other types of lenses.
So, from your experience, if you have like 10 patients with keratoconus, how many of them do you prescribe contact lenses?
In terms of soft or rigid?
In terms of rigid, because soft you can give it either to give glasses or soft. But what about the rigid? How many patients needs rigid contact lenses?
So in reality, apart from the very early, all of the patients they need rigid lenses. If they have good, of course, if you want good vision, because those patients we are talking about, they have loss of best corrected vision. When you have irregular astigmatism, you won't have 6/6 vision. You will have 6/12, 6/18, 6/9, whatever. So most of those patients will benefit from rigid cast permeable lenses. But if you ask me how many patients tolerate, contact lenses, not more than 5% of cases. Most of the cases they cannot tolerate.
So do you consult the patients about how to take care of the rigid contact lenses, or you just leave this to the optometrist to do so?
I will refer to optometrist.
You will refer to the optometrist. Because we know that it's like film رعب. when you deal with patients with contact lenses بالنسبة لأطباء العيون فيلم رعب في حين cosmetic contact lenses شو ما شاء الله منتشرة معنا. Because we fear of infection, we fear of
it's not like this. In the RGP, usually risk of infection very low, risk of complications very low. But the problem, the rigid cast permeable lenses, they are big lenses in terms of thickness, probably, and they are small in diameter. Okay, they are small in diameter. That's why they are cheaper, by the way. patient will start feeling them. They will have foreign body sensation.
Yeah.
But in terms of corneal health, infections, the soft contact lens is much more than the rigid glass membrane.
So if you have a patient with rigid contact lens intolerance, you go for scleral contact lenses, or you see that they're the same but just with the different names? What do you think?
No, for scleral contact lenses. If the patient cannot tolerate rigid RGPs in general, usually I will refer for scleral lenses, because these lenses are big. They rest on the limbus, okay, and they will avoid touching the cornea by itself. I mean, because of this clearance zone, so patients will tolerate much more. Of course, you have a lot of patients, they cannot tolerate the RGP, but at the same time they can tolerate scleral lenses. The problem with the scleral lenses, not the tolerance itself, okay? The problem wearing and putting off them. This is the problem with the patients. Patients usually, when they come to me about complaining about the lens, they do not complain about the comfort of the lens while wearing it. While wearing the lenses, they have very good vision. But the problem when they want to put it on or remove it, it's tricky a little bit. So they have to learn it from the optometrist, the special optometrist.
Yeah, we as a junior ophthalmologist, we are not that familiar with scleral contact lenses. I don't know, maybe it's new to our modalities or our, but the patient sleeps with it, right, or remove it at night?
They should remove it.
They should remove it at night.
Up to my knowledge, they should remove it.
And approximately how much it will cost for the patients? Approximately.
يعني ما عندي رقم معين، بس مكلفة هي شوية، مكلفة $700 or something يعني.
تمام. وهو يحتاج ل1 set، لا يحتاج أكثر من set على السنة؟ يعني إيش قد عفوا الشيلف لايف أو إيش قد يخلي البيشنت يمن؟
ما أذكر والله، ما عندي معلومة جدا واضحة عليها، بس أتصور يعني at least 1 year تبقى عندي.
تبقى عنده 1 year. فهو investment for a 1 year. So يعني
if not more than this يعني.
If more than حتى يعني to tell the patient about it. And there's a lot of debates about contact lenses, but if the patient cannot afford, or if the patient is refusing to have contact lenses, so what's your next option? The
next patient visual rehabilitation in terms of
visual.
And you pass the contact lenses and the glasses, and then the next step. Next step, most of the time, next step will be rings. If you have a vision which is like not sufficient for the patient in terms of the visual quality. Many patients, I cannot have a certain number, by the way. Many patients with 612, they do not feel they can see well, okay? If they are active, driving cars, reading, watching TV, using computers, they cannot see very well. So sometimes those patients, they will come for rings. On the other hand, when you have, people who has 624 vision, but still it's enough for them, housewives, they don't have that demands, they do not drive a car, they will accept, the vision. But most of the time, 618 is the dividing line for me if I will go for just rings, or will go after stabilization for phakic lenses.
618. And there's any degree that you like, any degree of stigmatism that you can choose between this or this? Or
between whom?
Sorry. How many degrees does the rings can correct of astigmatism?
Astigmatism. The ring itself, it depends on the thickness of the ring and the optical zone.
Okay.
Because if you go into smaller optical zones and with thicker rings, you might correct up to probably 11 or 12 diopters sometimes, even more. We have cases on topography, even more than this number. But the problem is then you are confronted with a lot of night vision problems. With the smaller rings, patients complain about the night vision. Currently, if we can go to this subject now, implanting cares, corneal segments, corneal tissues, corneal addition in general, they are gaining momentum nowadays. With these things, we can correct even more, 17 diopter, 18 diopter.
Without any compromising of the night vision, or we can go with?
I don't have long-term data about this, but yes, they do not complain a lot about night vision because this is just tissue. It's not like, you know, a plastic material inside the cornea, and you have a lot of refractions and reflections.
So we know that there are I think 2 to 3 types of rings available in the markets, right?
Rings, mainly the original one, the Intax,
Very.
which is from an American company, Addition Technology company. Kira ring from Medifacos, Brazilian company, I think, and Ferrara from again another company. Ferrara, I think, in Spain also AJL also manufacture this one. Up to my knowledge, these are the main 3 types. Of course, there are other types. For example, the Mayo ring, which is a complete ring. Also, it was popular like 10 years ago or 12 years ago, but I think now most of the people stop doing it.
So, and how you choose? What's your criteria of choosing a ring? Or which type, which segment? How many segments do you put? How do you decide?
I mean, there are a lot of nomograms.
Yeah.
For the rings, there are a lot of nomograms. No single nomogram is sufficient to produce the best results. That's why they are not highly predictable. But in general, there's a classification system or a nomogram, depending on a classification by Alfonso, which classifies the types or the shape of the cone into 5 types. Okay, it's a certain criteria. I think this, in my hand, it gave me the best results. Okay, and on this one, the problem with this type of nomogram, it needs the asymmetric rings, because previously the rings were symmetric in terms of thickness wise.
Yeah.
So the thickness along the ring diameter or span is the same. Now they produce rings which have different thicknesses.
Customizable, like you can choose
more or less. You have more types.
More types.
Okay. So because why? Just to cater for the asymmetry in the cornea. You don't have, rarely you have asymmetric bow tie. We said from the beginning. So you have asymmetry. This asymmetry needs more augmentation of the cornea. So they need thicker types of rings. But the flatter zone, they don't need that augmentation.
Thickness, yeah.
So they will need a smaller or less thickness. So they combine this into what we call an asymmetric type of rings, and they have a clockwise direction, anti-clockwise direction. They have different varieties of this.
And how do you take those measures? You put the patient on topographer and you fed the device with data, or just online site, I think?
I don't have online site. No, you have a lot of sites, online sites. You can even send the topography to the company itself. They can design the treatment for you. But usually I will just use the nomogram. It's a PDF document. You can fit the topography of the patient to the topography, selected topography on the nomogram, and then you decide according, because it comes into play, of course, the refraction also, the myopia and the astigmatism. Also, they are integrated into the nomogram.
And do you prefer putting those rings with mechanical or femtosecond?
Femtosecond, definitely.
Why such assurance, femtosecond?
I did mechanical, a lot of mechanical.
Yeah.
At the beginning, we did not have the femtosecond. So I did a lot of, mechanical insertion of rings. With the mechanical insertion, the centration is an issue. It's a big issue. Okay. The depth of insertion is again a big issue. And the extrusion rate is much more than the femtosecond. With the femtosecond, I have 0 extrusion rate, 0, for the last probably 10 years, more than 10 years.
Okay, that's good.
0 extrusion.
Yeah.
Probably I explant okay, but no extrusion. Okay. But the problem with the mechanical, no, I have probably 15% extrusion rate.
So, and what's your major drawbacks of rings? What's your most feared drawbacks, and what's your major common drawbacks?
Rings usually main drawback is unpredictability. You cannot say to the patient, you will get better or worse. Okay, most of the time they will get better, but to a slight extent. Okay, usually the amount needed to correct, their vision is much more than what is given by the ring. This is one of the things which you can exchange for a thicker type of ring sometimes, or can augment with combined PRK plus cross-linking. But most of the time, this unpredictability is the major issue. And second, if you use smaller types of rings, you get a lot of night vision symptoms.
Night vision.
With the bigger types, 6mm zone or 6.5mm zone rings, usually the night vision symptoms are very low.
Okay. I think we just jump into something before we jump to other. We only talk about how to treatments of refractive errors of the patients, but we missed the progression, how to hold the progression. You told me about I think the only way is cross-linking. You cannot hold the progression by anything else, right?
It depends on the theory. Again,
on theory.
Yes,
okay.
The theory of etiology. Because if the theory of etiology is just the eye rubbing, okay, and the inflammation does not play that much role, okay, and the process is not a continuous process, let's say, then if you halt the eye rubbing, or you prevent the eye rubbing, or you stop eye rubbing, most of the cases they will have no progression. We have plenty of cases now. If you tell the patient, and the patient knows from examining or being examined by several doctors, the patient knows that he has the disease process, and this disease is mainly caused by eye rubbing, and they stop eye rubbing. Okay, really, they stop eye rubbing, some of them. So many of them will not have any progression.
Okay.
And they have patient 1 or 2 or 3 years. Okay. But if the patient cannot stop eye rubbing, okay, then the modality of treatment is known. Okay. Some people argue, some doctors or some scientists argue that this modality of a treatment, once you do it, the patient will stop eye rubbing. So the treatment is stopping the eye rubbing, not the
الدجاج البيضاء البيضاء من الدجاجة والدجاجة من البيض.
فهذه مشكلة يعني، لأنه المريض عادة راح يسوي عملية معروفة هي في مجتمعاتنا كلها، يعني تدري حتى بالكاتاراكت وبغير، يعني يسوي عملية بعد يحاول ما يلمس عينه، يخاف منها.
اوكي.
يخاف، يقول لك أنا العدسة تتحرك، تصير مشكلة كذا، فيعني دائما they avoid touching the eye.
So if we but you choose to do cross-linking for the patients, which we know the Dresden protocol, the old Dresden protocol with 30 minutes lightening, 30 minutes. Do you still use it?
The problem in Dresden protocol, not use it from the beginning.
From the beginning.
From the beginning. احنا يعني تعلمت من ناس بالحقيقة هم شغالين في بهاي المنطقة بالميدل ايست بصورة عامة. وtheir يعني conclusion is correct. احنا المنطقة the high ultraviolet light, it's just a lot of sun, okay, a lot of sunshine هنا. فالمشكلة if you do a lot of cross-linking for the patients, اتوقع انه المشاكل العكسية له، اللي هي المشاكل العكسية شنو؟ a lot of scarring, a lot of haze, excessive flattening for the cornea, and even late extreme flattening. I have seen patients after 10 or 12 years, they have flattening in terms of, I'm talking about 10 diopters, okay, if not more. So they have a K reading of 34 or 35 diopter. I have a patient now. She did the cross-linking like more than 12 years ago. So that's why minimizing the time, the Dresden protocol says that you have 30 minutes light exposure usually. Minimizing the time, I think, is feasible for our practice, our environment, our locality.
So epi on, epi off.
Epi off.
Epi off.
100% epi
Why
off.
not
I tried the epi on.
Yeah.
Tried the epi on. Epi on, without a way of getting the riboflavin diffusing into the cornea, which needs special medication, I think. You will not get that effect.
So, if I was your assistant and you sent me a patient with a cross-linking, what is the parameters that I am putting in the device? We know that this is not the Dresden protocol. So what's your parameters?
Riboflavin sucking, okay, riboflavin sucking, it depends if you use a ring or a well, okay, or not.
Okay.
And if you do not use a well, okay, you have 30 minutes of, you should
Sucking.
have 30 minutes of sucking. If you use a well, 20 minutes is enough, okay? Because at that time, the riboflavin will be in constant exposure. The UV light exposure depends on the machine itself, whether you use accelerated type or a normal type. The normal type usually is 20 minutes, okay? But with the accelerated type, you have an exposure of 10 minutes only.
10 minutes.
Okay, 10 minutes you can shorten it to 8 minutes.
Right.
8 minutes in most of the cases is more than enough. If you have the type with the 5 minutes, okay, highly accelerated type, you can use 4 minutes. By the way, in all these varieties now, they use something which is called a pulse mode. If you have a pulse mode, because this will provide more oxygen during the reaction, this will provide better cross-linking.
And last thing about cross-linking is that you have cross-link the patients, and do you wait for how much time before you put rings, for example?
You can do it anytime, but yeah, usually you wait for most of the staging. I tell the patient, usually I do not do repeated or sequential surgeries not less than 6 months. Usually I wait 6 months for the next surgery to be done, whether this putting phakic IOL, putting rings, doing topo-guided treatment or PTK, whatever. Usually I like to wait at least 6 months.
And if you have, we know that there is some trend now by Dr. Fouad Issa. He's doing what's called as customized cone cross-linking.
PACE, I think they call it PACE.
What do you think?
They claim very good results. They claim this is like a refractive correction because they treat mainly the cone. The idea is treating only the cone with a high fluence cross-linking, and then the areas surrounding the zone, they will treat with less cross-linking. But before they do PTK for the epithelium, okay, they will do, I think, 50 micron PTK to level up to remove the epithelium. So they claim that there is no tissue removal, but it's still refractive correction. And I think they have results of like 6 or 7 diopter change from this type of a treatment in which no tissue was lost. Because you are not doing, PRK for the stroma. You are just doing PTK for the epithelium. And then they will cross-link in a sequential manner. But they also need some, because the epithelium will be removed only on, I think, 2 to 3 millimeters around the cone.
So they need like PTK customized topography PTK or PTK with topography.
PTK centered on the cone itself. They need medications to enhance the penetration of riboflavin because they will not remove the epithelium. And they need high fluence cross-linking with decreasing concentric fluence. So all this is designed for their I think it's called CI instrument. CI. This is a portable type of cross-linking device invented by Fouad Issa, which can be used for slit clamp cross-linking, and at the same time can be used for ambulatory or for supine position. So this, I think they have it already in this machine.
So if you want to take some water before we kind of proceed. I think we now stabilize the patient. We now give him some minor refractive treatments like glasses or rings, maybe things. But do we have other options? We said that we can go for a toric IOL.
For phakic lenses in general. I mean, before the IOL is something else. You are talking about phaco.
Yeah.
I was talking about usually those younger patients. They have clear lenses. معظم الأحيان we want to do refractive correction for them using phakic lenses. As the phakic lenses, عادة, which patients they benefit more from the phakic lenses, which I use only the ICL, by the way. I do not use anterior segment and iris clip lenses, but I use only the ICL. Usually the patient's benefit depends on the best corrected vision. If the best corrected vision is better than 612 or 618 to 612, usually they have a dramatic improvement and correction of refractive errors using the phakic lenses.
Okay, and if you have the ability to use scarce, the contact, the rings with the corneal transplants, do you will use it? You will prefer it?
No, at the moment I prefer it on the ring.
On the rings.
At the moment I prefer it on the ring. Okay, I'm trying to do now. Probably I did like 15 cases. Okay, they have dramatic improvement.
We did it in Iraq.
Yes.
Wow.
Yes.
That's good.
I did it. The improvement in terms of topographic improvement, the flattening effect of the care segment is much more than any ring. You know?
Okay, that's good. And
I hope so.
For me, I think this is the like. المفروض نستعرض عضلاتنا, but I think we have to also to document it with the medical research. So we have 2 projects now. Inshallah. So, and when you choose a corneal transplant for the patients, what's your when you will go into your last treatments in our material?
واعتقد الكورنيال ترانسبلانت يعني اصبح دوره قليل هو صراحه هسه في الوقت الحاضر. احنا معظم المرضى اللي نشوفهم حاليا you can manage in some sort. يبقون بس المرضى اللي هم they have corneal opacities. When you have acute eye drops in a patient and they heal and they will have large prismatic defect and large corneal opacity, the only option to do is probably the transplant. And the other group of patients, they will have some patients, especially when patients they have severe allergies, severe vernal keratoconjunctivitis at an early age. Usually those children, you cannot prevent them from eye rubbing, and most of the time the parents, they cannot, or the family cannot appreciate the complexity of the visual deficit in the patients, so they present late. Okay, still we see some patients, they have severe type of keratoconus, extreme thinning, a lot of box striae. You cannot put a ring, you cannot put probably the cares they have a role in these patients, but with some of them still the DALC or keratoplasty is needed.
And you'll go for a DALC, deep anterior lamellar keratoplasty.
You try your best to do the DALC in any patient with keratoconus, even if you have a high drops, if the patient had high drops. Sorry.
Any preferred technique? We know a lot of techniques available in the DALC. Any preferred technique that you'll choose, or you'll depend on the situation?
No, it's a big bubble technique. Most of the time it's big bubble technique. This is the best. If you can expose the distal membrane easy with the big bubble, it's a very easy surgery. Other than this, you go to a manual type of DALC.
And I don't know if you are familiar with what's called as evolving intrastromal stem cell transplantation.
سامع هالشيء صراحة, بس ما عندي خبرة يعني stem cells, they can stem cells they are being used for everything.
احنا ما نوقف ننزل stem cells.
فاحتمال كبير جدا هي الفكرة. اعتقد يعني يجوز بالانتراسترومال if you put stem cells to regenerate the cornea. يعني تدري هنا عندك defect loss of collagen بالكورنيا, وهي هاي المشكلة اللي حدنا عن Etiology of Keratoconus من تقراها او تسمع من العلماء الموجودين, still there is no exact cause of why it's happening. فجزء من تعويض التشو هذا ممكن أن يكون قد يكون هاي الستيم سيلز إذا كانت they differentiate into another collagen, new collagen, and this collagen will arrange naturally عرفت شلون to give clarity for the cornea. طبعا شغلة ممتازة يعني أكيد.
I think we have reached to our last question, which is what is your favorite staging system?
والله simple staging system. Clinically هذا يسموه مكمهون classification, اللي هو mild, moderate and severe depending on the steepest K. اوكي نشوفه. هذا عادة very simple in the clinic. فائدته الرئيسية as a prognostic بالحقيقه بروجنوستيك كلاسيفيكيشن فور ذا سيك اوف ذا بيشنتس، لانه عاده البيشنت راح يسالك مباشره الحاله مالتي صعبه سهله متوسطه معقده شنو الوضع. انت في هذا السيستم البسيط المايلد مودريت سيفير وادفانسد عاده انا اخلي له اذا في there is a scar I will tell them it's advanced other than this mild moderate severe. هذا يفهم المريض بسهوله صراحه يعني. بس staging system in terms of diagnosing خلينا نقول following up the patient، المشكله يحتاج ماشين. يعني مثلا هسه انت عندك الاي بي سي دي كلاسيفيكيشن اللي هو موجود يمكن على البنتاكام اعتقد، ما اعرف بعد دخل على ماشين اخرى. هذا المفروض انت عندك بنتاكام بحيث تاخذ المريض اليوم وبعد 6 شهور بتقارن انه الاي بي سي دي كلاسيفيكيشن مالته هل هو احسن اسوء الى اخره. ممكن يعني يصير عندك نوع من الستيجنج سيستم في مناطق مختلفه. كلاسيفيكيشن اخر يجوز مثلا تلقاه في ماشين اخرى فنفس الحاله، بس بالحقيقه مو انترتشينجبل هذه الكلاسيفيكيشنز ولا ايزي تو كالكوليت. انت وقاعد بالكلينيك وتريد تاخذ يعني تعطي كلاسيفيكيشن او ستيجنج للبيشنت. وين راح يفيدنا الستيجنج او الكلاسيفيكيشن؟ يفيدنا بالسلكشن اوف ذا رينجز اللي هو بالحقيقه غير كلاسيفيكيشن. يعني مو هذا قلت لك الالفونسو، انا حاليا اعتمد على الالفونسو كلاسيفيكيشن. اذا يصير عندك فرصه شوفه جدا لطيف الكلاسيفيكيشن، وبالحقيقه هي هاي الكيسات اللي نشوفها احنا بالتوبوغرافي بالكلينيك نشوفها، والفيتنج صعب انه تجي تروح تخليها على كلاسيفيكيشن اخر وغير. يعني صراحه ما كلش يعني تستفاد من عند امسلر كرومخ كلاسيفيكيشن مثلا راح تستفاد من عنده تقول هذا ستيج 1 او 2 او 3 او 4، ما كلش يفيدك بالتريتمنت. فعندك هذا عندك البسيط جدا اللي هو مايلد مودريت سيفير ادفانسد، وعندك الكلاسيفيكيشن الثاني for the sake of the rings.
بس we ask our last questions راح يصير لك انت what do you think we must يعني شنو السؤال اللي احنا ما سالنا شنو جوابه؟
صعب انت وايد سالت اسئله.
يعني قبل ما ناخذ الاسئله مال شو اسمه مال الاودينس
ما عندي شيء صراحه يعني.
زين خلينا نشوف الاسئله مال الاودينس.
يعني لو سالني عن المس دايجنوزز مثلا مس دايجنوزين كيراتوكونس rather than diagnosing keratoconus.
اوكي.
يعني تدري احنا بكل التيست اللي نسويها يعني بعملنا الطبي انه نشوف دائما اكو فولس بوزيتيف فولس نيجاتيف. يعني هسه الفولس نيجاتيف يمكن تكلمنا عليه انه احنا ما نريد ويمس دايجنوزز اوف كيراتوكونس، بس مشكلتنا احنا مرات نريد نشوفه انه موجود عندنا اوفر دايجنوزز اوف كيراتوكونس. نشوف مرضى كثيرين يجون بالحقيقه سواء هنا او خارج البلد طبعا. هذا نشوفه انه هو هاز خلينا نقول some sort of congenital astigmatism، بس تشوفه هذا رايح ومسوي معتبري كيراتوكونس ومسوي كروس لينكينج وجايني ورا سنه وسنتين وثلاثه. عندي مرضى كثيرين من ذولا يعني بالحقيقه. هسه انا ما اقدر اقول له انه انت يعني تشخيصك يعني خطا بالحقيقه، بس يعني انا اشوف هذه مساله المفروض ماكو داعي. يعني دائما يمكن قبل فتره الشباب قلت لهم ماكو داعي للتسرع في تشخيص الكيراتوكونس. It's not a highly urgent, it's not a life threatening خلينا نقول diagnosis، بحيث انه انت يجب انه تروح الى الدايجنوزز بسرعه عظيمه جدا وتروح الى التريتمنت بسرعه عظيمه جدا. هذا الاطفال يمكن اللي 12 13 سنه يعني قلت لك ذول الاطفال لازم تكون انت يو ار شور، لانه هذا الطفل يعني تدري انت اكو بحث مهم جدا بالحقيقه في الكروس لينكينج انه شنو الريسك فاكتورز فور impaired vision after cross linking. بالحقيقه patient with 6/6 vision هذول عاده راح يصير عندهم loss of best correct vision ممكن بسهوله جدا. يعني انت ممكن اي opacity تصير عندك، اي excessive reaction، اي haze formation عن الموجود، اي infection ممكن يصير، epithelial healing، dryness، هاي كلها الامور موجوده بالكروس لينكينج. يعني كلها ممكن تسوي لك شنو. فهذا دائما ريسك فاكتور انه if you see a patient with 6/6 انا عاده حتى لو keratoconus I'm very hesitant to treat this patient. I'll be very careful about advising any treatment for the patient in terms of cross linking. فهذه النقطه يمكن الوحيده اللي يمكن الشباب اللي او الاشخاص اللي يسمعونا حاليا انه تشخيص الكيراتوكونس يجب ان يستند الى قواعد علميه. يعني لا يكون انه اي كيس نشوفها هي مجرد انه اكو استجماتيزم والمريض عنده تشينج شايل بريسكريبشن مال نظاره قديمه مثلا ماينس 1 سلندر، احنا شفناها هسه ماينس 3 او ماينس 4، نقول هذا صار اذا كيراتوكونس. هاي شويه بس
يعني هو I think انهم because of the easiness of doing cross-linking we are يعني more reluctant to do it.
بس still there is risk.
Yeah,
موجود
this is
infection
the main
موجود.
this is the main يعني this is the main thing.
Dryness for the patient and recurrent corneal erosion. Recurrent corneal erosion syndrome after cross-linking is very common.
Yeah, for this reason, I didn't ask you about why not doing a second or third or fourth cross-linking. I know that you don't prefer this for your patients, but you know that okay, it's just a cross-linking. You see,
يعني الريتريتمنت او الفيلير ريت جدا قليل بالكروس-لينكينج، جدا قليل صراحه بالكروس-لينكينج. If the patient stops iRobin. يعني انا عندي مريض واحد اتذكر او اثنين اللي هم مسوي لهم ترانس ابيثيليال كروس-لينكينج وصاروا بروجريشن. شلون؟ فاضطريت اعيد الكروس-لينكينج ابيثيليوم اوف. بس عدا هاي ما عندي، يعني ما اتذكر من مرضانا انه ناس احتاجت انه ريبيت كروس-لينكينج several times.
زين. نشرب ماي شويه حتى
هيك زين الامور.
زين.
انت اخذ اسئلتك شوف.
لا هسه سالنا دكتور مضر. He said that which is the better results, traditional or accelerated cross-linking? I know that you don't do any traditional, but
traditional I did in 2007 يمكن او 6. I started doing cross-linking the traditional. traditional way of doing it. ما كان اكو accelerated machine صراحه، يعني يمكن ورا سنوات صار في موجود عندنا الاكسلريتد. ريسيرش كثير عليه موجود صراحه، بس اعتقد بالسنوات الاخيره الاكسلريتد اثبت نجاحه يعني. بالبدايه الريسيرش الاكسلريتد الافشنسي اقل او الفلاتنينج اقل. فاهم شلون؟ طبعا المشكله الرئيسيه احنا نخلي ببالنا دائما بالكروس لينكينج هذه، يعني الامور يمكن لا احد يعجبه يروح يقراها في موقع داميان جاتينال، هو مشهور يعني هذا بالاوبتكس، هو الرجل يعني ophthalmologist بس اوبتكس ساينتست يعني at the same time. عنده شرح كبير جدا على مساله انه اعتراف على مساله انه السكارينج we are inflicting scarring in the cornea using cross linking. فلذلك يعني بالحقيقه احنا we are doing something unnatural او unphysiological to the cornea when doing cross linking. نعم ما عندنا other modality of halting the progression other than this، بس بالحقيقه هو يعني قد يكون مو هي هذه ideal way of reinforcing the corneal structure. فمع ذلك يعني تسالني traditional والاكسريتد حاليا the same outcome.
I think Dr. Haider asked about can we use the intracorneal segment rings then cross-linking for the patients or you have to do cross-linking before?
كل الريسيرش يقول ماكو ديفرنس، اذا تسوي الرينج اول شيء وبعدين كروس لينكينج، او تسوي كروس لينكينج وبعدين الرينج، او تسوي combined together at the same time.
You can do both of them.
كل الريسيرش تقريبا the same.
And what you prefer?
I do this if I decide I do both of them at the same time. لأن الرينج مشكلته الرئيسية usually after 6 to 8 months you start losing effect. فعادة you need cross linking. المفروض تقدر تنتظر ل6 شهور طبعا، يعني do rings and then you do cross linking. الايديا انه you lock the cornea على اساس على الشكل الجديد، بس ما تاخر المريض فتره طويله لانه احتمال كبير تاثير الرينج يروح بعدين.
زين. دكتور معتز يقول what about optimizing dry eye and allergies pre-cross linking?
It's very important يعني حلو. سؤال حلو يعني هو بالنهايه انت باي سيرجري انت تسويها صراحه whether cross linking refractive type يعني ليزرز ليزك cataract surgery انت you need to have the best ocular surface health. اولا prevention of يعني infections، improve healing process بعد السيرجري هذا راح يكون عنده، و increasing the comfort of the patient. يعني بالنهايه يعني اكثر شيء يزعج المريض هو بالحقيقه هو البين بعد السيرجري، الاريتيشن موجود، الدراينس، فكل ما انت تحسنها prior to surgery طبعا اضافه للايرابنج يقل والى اخره يعني التفاصيل كلها.
زين. هو انا اكو اوكي خلينا نحكي هذا السؤال من دكتور راني يقول how fast should we do cross linking in a child with established keratoconus once sign positive؟
هذا immediately ما عندك.
immediately within a week.
children عادة يدوا immediately ما عندك schedule يعني هي next list. يعني اليوم انت عندك الليست بعد 3 ايام سويها بعد 3 ايام.
So, and Dr. Haider asked about what is your opinion about what's called LASIK extra. That's to say cross-linking plus LASIK. We missed this topic by the way.
لا هذا موضوع يعني كبير هو الريفراكتيف سيرجري. احنا despite doing it مرات بالحقيقه مرات قليله جدا انا مقل بهن ذني. الريسيرش يقول انه نو بنفيت. يعني انت الفكره وين هي الرئيسيه؟ انت منو اللي تختاره للليزك اصلا؟ منو تختاره؟ انت اي مريض اللي انت راح تيجي تختاره تقول هذا اسوي له ليزك. اكيد هذا مريض ما عنده كيراتوكونس او كيراتوكونس سسبكت او سب كلينيكال كيراتوكونس، صح ولا لا؟ ما عنده هذا الشيء. بس منو نختار مرات احنا بالحقيقه؟ نشوف مرات ثين كورنيا مثلا لاطمئنان الجراح اكثر من الاطمئنان العلمي. هو حتى الجراح يطمئن يقول انه انا ما سويت شيء للمريض ممكن بعدين ورا فتره تصير مشكله اخرى او اكسسيف ويكنينج. هذا الليزك اكسترا يمشي. بس هو بالحقيقه مقابله قلت لك كريسيرش ماكو اي فرق كبير جدا بين انت يدو ليزك او يدو ليزك اكسترا in terms of stability. وللعلم احنا من نقول ليزك اكسترا انا ما اقول واحد يجي يسوي يقول لي عندي M2 مايكرو كيراتوم وجاي يسوي كورنيا 490 مثلا واريد اسوي ليزك اكسترا وياها. يعني هذا يعني اعتقد
do you want thick corneas or do you want femtos؟
لا يعني انت من تتكلم على refractive surgery in patients with borderline corneal thickness انت ما تقدر تروح على instrument اللي هي unpredictable in terms of thickness. لانه انت راح تدخل في مجالات غريبه. يعني انت منو قال هذه الفلاب اللي انت تسويها مو هي 170 مايكرون؟ شلون تعرفها انت هذه عادي جدا بالمايكرو كيراتوم. بس الفكره وين اذا انت تتكلم لي على فيمتو سكند ليزر استعمل فيمتو سكند ليزر which I advise highly طبعا لكل الشباب الموجودين يسمعوني. يجوز انه انا ضد استعمال المايكرو كيراتوم في حالات الريفراكتيف سيرجري لانه انت راح تدخل في مشاكل انت في غنى عنها. نعم يقولوا لك predictable يقولوا لك كذا cheaper option بس هي it's a matter of giving or providing the best treatment possible for the patient. نعم راح يدفع المريض ازيد قد يكون بس انت من تتكلم عن standard deviation of 5 to 7 مايكرونز مو مثل تتكلم عن standard deviation 30 مايكرون. تفرق طبعا يعني هاي كثيرا. الايدج مالتك راح تفرق كثيرا يعني وتفاصيل كثير يعني.
زين I also missed the questions is about what do we know what's your pachymetry or what's your corneal thickness in cases of cross-linking 400 micron.
لا ما انت تقدر تستعمل هسه حاليا السب 400 بروتوكول.
اوكي هو هذا
بروتوكول
if you have a thin corneas
سب 100 يعني سب 400 بروتوكول اكيد تقلل التايم اوف كروس لينكينج to save the endothelium. Still they have the same effect. Will have the same effect.
يعني you don't use the hypertonic I think.
توقفنا عنه. سابقا كنا نستعمله قبل ظهور السب 400 بروتوكول كان نستعمل الهايبوتونيك العفو رايبوفلافين. حاليا توقف ما اعتقد حتى ما حد يمكن قليل جدا يستعمله.
زين. Dr. Mu'taz also asks about do you use corneal wavefront or is iTrace? He said iTrace technology in keratoconus and he uses. But I think I'm going to generalize the questions. Wavefronts in patients with keratoconus. Does it make any difference for your management?
المانجمنت ما اعتقد يعني جدا بس in terms of يعني reinforcing the diagnosis. عادة انا راح يعني تجيني يعني I order a print out of iTrace الويف فرونت chunk analysis يسمون ويف فرونت analysis اللي هو به التوتال ابيرومتري وكورنيال ابيرومتري والانترنال خلينا نقول او اوكيلر.
الانترنال الانترنال ياخذ الطرح
يعني هو ياخذ التوتال وياخذ الكورنيال ويطرحها. فالكورنيال انت راح يهمك الكورنيال تدفرنشيت طبعا راح تشوف تدفرنشيت الكوما ابيريشن. كوما ابيريشن اذا شفتها mainly corneal وعاليه عرفت شلون؟ هذه reinforcing diagnosis of keratoconus ممكن يعني. بس in terms of treatment المشكله يعني تقول لي ماكو انتجريشن بين الاي تريس والليزرز. الانتجريشن بالليزرز الموجوده من التوبوغرافرز، عاده كل شركه عندها توبوغرافر انتجريتد وياها، اللي مثلا زايس عندهم اطلس توبوغرافر، الويف لايت اتصور عندهم،
شويند عندهم السي اس او هو نفسه،
شويند عندهم بالضبط، عندهم السايرس وغيره. هذا ممكن اللي يريدوا يسوون بي ار كي، يعني توبو جايدد بي ار كي فور كيراتوكونس، اللي ايضا انا مقل به صراحه يعني، بس هذا واحده من الموداليتيز مال التريتمنت المهمه.
يعني هو احنا نرجع نفس السؤال الرئيسي بانه what's your main refractive surgery for a patient with stable keratoconus؟
انت هنا يو ديفايد تو، عندك واحده good best corrected vision fake IOS.
fake IOS اوكي.
low best corrected vision I'll do rings for them.
And there is no rule in your practice.
لا I have a rule for PRK or PTK for keratoconus plus cross-linking. بس I do هاي المايل cases عادة stable for at least 1 year. stable at least 1 year without treatment by the way. يعني البيشنت يجيني اليوم اشوفه بعد سنة stable without treatment, I will advise PRK plus cross-linking at the same time.
So, Dr. Mu'taz also asks, any rule of arcuate keratotomies?
ما أعتقد، هو طلعت قبل فترة، مو هسه، قبل سنوات طويلة circular keratotomy مو arcuate. circular keratotomy طبيب كان بالأردن يسويها، يمكن هي روسية الطريقة أتصور، قبل 20 سنة، وبعدين راحت اختفت، وقبل سنوات طلعت. بالحقيقة يعني الفكرة انه انت to divide the cornea، انه انت creating يعني فد barrier بين الليمبس وبين الزون of the cone. Once you do the circular keratotomy it will flatten, the patient can see better. بس هي logically speaking انت are cutting fibers، يعني ما راح تكون طبعا ما راح تكون هي optimal treatment.
Okay, I think we gonna end the podcast because there is no questions anymore.
Inshallah.
We've passed about راح يصير 100 minutes ساعة وثلث.
جيد.
الحمد لله. So to end everything, we are gonna ask you طبعا thanks for Dr. Ammar for your efforts and thank for the extensive. Sorry تعبتك.
لا بالعكس أنا أشكر شركة أجانتا أيضا طبعا على الاستضافة، وأشكرك أنت بالذات والدكتور معتز اللي مع الأسف ما قدر يحضر يعني. إن شاء الله
بالأيام اللي جاية إن شاء الله مع الله سلامتك. Thank you all. We are gonna see you in another episode regarding another hot topic in ophthalmology and will be announced later.